right, so good afternoon, everyone. Welcome to the Yale Sleep Medicine Grand Rounds. My name is Ritika Thapa. I'm one of the pulmonary critical care and sleep medicine faculty here at Yale. Just some brief housekeeping announcements before I introduce our today's speaker. Please take a moment to ensure that you're muted. And in order to receive the CME credit for attendance, please see the chat room for instructions, and it will come repeatedly. You need to sign up to get credit, and if you have not done that already, please send a message to Debbie Lovejoy. And if you think anyone else is interested in joining, please reach out to her as well. And if you have any questions or comments during the presentation, please use the chat room or take the opportunity to unmute yourself at the end of the talk, and you can ask the questions yourself, and I will also moderate the session. And recorded versions of these lectures will be available on YouTube a few weeks after the presentation. And I have the extreme pleasure and honor of introducing Dr. Jorge Mora today. Dr. Mora received his medical degree from Universidad Central de Venezuela, Caracas, from Venezuela. He then completed his internal medicine residency from Albert Einstein Medical Center, followed by his geriatrics and pulmonary critical care fellowship, and then another fellowship in lung transplant at Toronto General Hospital in Canada. He's currently a professor of clinical medicine at Perelman School of Medicine at the University of Pennsylvania in Philadelphia. He's currently the medical director there of Penn Sleep Centers, associate chief for clinical affairs at the Division of Sleep Medicine, and the director of the NIV program at the Hospital of UPenn. He has lectured in courses in sleep disorders and NIV nationally and internationally, and I also had the opportunity to present together with him at CHEST. And he has also received many awards, including the Allen Pack Teaching Excellence Award at UPenn, and he's been named top doctor in the Philadelphia Magazine since 2018 until 2025. He's also authored many publications, and he serves as a reviewer of several journals. Thank you so much for being with us, Dr. Mora, and without any further delay, I would like to hand it over to you to share your expertise on inpatient to home NIV transition.
Thank you very much. I think I'm getting older based on how many things you said. That's all it means. It doesn't make me wise, just old. So I just put this here for, I guess, so you guys can get your CMAs. We're going to talk about, and saying all that, I forgot to say thank you for inviting me. So I really appreciate it. It's an honor. I actually was talking yesterday to Clemente Brito, who he was my resident, and he sent me a picture of the flyer, so it was funny. So anyway, I really appreciate you guys inviting me. So we're gonna talk about inpatient to home non-invasive ventilation transitions. We're gonna use 4 stories that I will show you soon to essentially get to one specific objective, which is my life is pretty simple. I just try to reduce CO2 in people, and it takes many steps and many different approaches to do this. We're going to talk a little bit about hypoventilation. We're going to talk about non-invasive ventilation management strategies and pathways to qualified patients for devices and transition from home to hospital. As I mentioned before, I'm going to use 4 stories, and I just titled them The Smoking Gun, The Smoker Gun, The Triple Shot, and The Missing Diaphragm. I will avoid jokes in this presentation because I have learned that jokes in virtual presentations are really awkward because you don't get any feedback, and it sounds weird. So oxygen has things relatively easy in life, and the reason I say this, it's partial pressure in the atmosphere is pretty high. There is a pretty high gradient between the alveolar space and the arterial space, and that means that it using that grading is enough to go from one space to another. CO2 is a different story. The grading is not as large. It's non-existent out there. But from the capillary space to the alveolar space, it needs to get pumped, because otherwise, by diffusion only, won't get many places. This pump function is what we call ventilation, and the volume we move with each breath is tidal volume. Obviously, if we multiply that, and these are not novel concepts, for anyone, but I just wanted to review them briefly. We multiply by respiratory rate, you get minute ventilation, which is the amount of air you move in 1 minute. Minute ventilation, it's inversely related to CO2, meaning the more air you move, the more CO2 you carry out, the lower your CO2 concentration, your arterial side is. Hypoventilation is defined by this, is defined by a decrease, an effective decrease in minute ventilation, which translates in hypercarbia. That decrease in minute ventilation needs to be very specific about a decrease specifically in alveolar ventilation or effective alveolar ventilation. You could have the same minute ventilation, but if you have the proportion of the dead space ventilation in that minute ventilation is larger, you will have hypercarbia despite a steady minute ventilation. Hypoventilation, pathophysiologic mechanisms are those of either your pump doesn't work, your pump works, but it's very restricted in how much air it can move, or the air that is moved does not clearly participate in gas exchange. And the concept behind this is that in the specific case of neuromuscular disease and thoracic wall, there is a pump failure, and it's also shared by obesity, by restrictive hypoventilation mechanisms. It all translates in a decreased tidal volume, decreased minute ventilation, and increased CO2. COPD is a slightly different animal, and in the sense that dead space ventilation plays a significant role in this. And mechanical dysfunction as well, the flattened diaphragm and the geometric changes on the diaphragm make it more ineffective, decrease in respiratory function and decrease in ventilatory reserve. So all this will eventually translate in hypercarbia to a smaller or larger degree. Regardless of what the pathophysiology is, we can think about hypoventilation in three broad categories, and one is neuromuscular disease that encompasses also restrictive cage, obesity hypoventilation, and COPD. In the obesity hypoventilation, if you want to talk about qualification, all hypoventilations are placed in the same bucket, meaning if you have pulmonary fibrosis, that restriction, it goes into the same bucket in terms of device classification, and that's why I put this into these three broad categories. But believe it or not, the fact that it's defined by obesity hypoventilation for qualification makes it complicated sometimes to get a device for patients with non-obstructive or non-neuromuscular hypoventilation. Our objective in general, obviously, is to increase minute ventilation, and the goal is to decrease CO2 in these patients with hypoventilation. We are not very creative in sleep medicine, and I think we're basic. And what I mean by basic is that we do one of two things or a combination of both. One is we are able to pneumatically stand the airway. We can ventilate without producing necessarily much stenting of it. And we can do both when airway collapse and upper airway collapse and ventilation disorders coexist. The objective of decreasing the CO2 must be achieved by effectively increasing alveolar ventilation. That is an important concept because in patients, for example, with COPD, we may be ineffective in enhancing ventilation by providing too much oxygen, just to give a simple example, and just producing hyperoxic hypercarbia. And that defeats the purpose. And so it's important to remember that that's the objective, and we need to take into account mechanisms that affect dead space ventilation and increases it. Non-invasive ventilation, and I think, and a stenting of the airway implies quote unquote, injecting air into the respiratory system using positive pressure. The big difference here, and that's where the concepts between invasive and non-invasive ventilation is that things are more steady and more measurable when we use invasive ventilation. And what I mean by this is it's a closed circuit to start with. And what we introduce in this whole concept is that in non-invasive ventilation, even though you can have active circuits, most of the times we use passive circuits where the exhalation and the release of CO2 out of the system occurs passively through leaks in the system. And this makes measurements and steady ventilation more complex and requires that algorithms within the devices are able to analyze this. On the other hand, this particular need also has taken to devices to be able to manage leak very well, as it happens in home mechanical ventilators, which is not true for invasive ventilators typically used in the ICU. You have a leak, and if probably you know that these ventilators go absolutely insane. That is not true for ventilators that are designed for non-invasive ventilation. We use two essential modes to either stent or ventilate and ventilate at a stent, and those are continuous positive airway pressure, or CPAP, and bilevel PAP. I don't think I need to explain this too much. EPAP, you have a constant pressure with some variation in pressure between exhalation and inhalation, and in BiPAP, you have an increase in respiratory in pressure during the inspiratory phase of the respiratory cycle that creates that concept of bilevel, and it's not different from pressure support in invasive ventilation. And if you equalize, let me silence this. And if you're able to equalize in pressure support in a regular ventilator, IPAP to EPAP, you're essentially using CPAP. The problem is that there is no true airway stenting because it was already stented by the ET tube or the tracheostomy. Non-invasive ventilation and CPAP, it's essentially pumps that are driven by algorithms, and those algorithms differ between different devices. The interesting thing is, I mean, we have CPAP on one side that it can be self-adjusting, and then we have bilevel PAP with multiple modes, including spontaneous, and we'll go into way more detail on this, and spontaneous and time and bilevel PAP. And then we have more complex modes of ventilation, and essentially they're not truly modes. All of this is pressure cycle ventilation, and it's essentially pressure support. You just have very ways of reacting to different user and the device interactions. And in the middle, we have something that is somewhere in between, that is actually a bilevel device that is used to treat a sleep apnea, essentially to a stent, which is the mode that is called auto bilevel PAP. ASV also has a little bit of a stenting capabilities. So the way I look at this in many ways, I don't know if you guys remember that Google years ago launched a phone where you could put different modules, and if you're a photographer, you will put a better camera. It's the same thing. You can have a small, think about this as devices that have a small functions as auto CPAP, and then you add pressure support, etc. So it's just algorithmic and the way how the machines work. That being said, auto CPAP is a simpler mode, and I'm going to go into much detail into this. It's able to assess flow limitation, snoring, vibration, and based on this, will self-adjust within a predefined range what the EPAP pressure is. In auto bilevel, depending on which brand you're using, and since Philips is out of the equation in many cases, we usually have now a fixed pressure support, and essentially when you do auto bilevel PAP, which is used again, and you should think about it as a mode to treat a sleep apnea and also as a ventilation, which it's true and false, as we will see. But The problem is there is no sensing of volume. There is no targeting here. It's just the difference between the IPAP and the APAP will be the same during the whole respiratory cycle, and when the pressure adjusts, is adjusted on an algorithm based on flow obstruction and flow limitation. ASV is very different. It was designed for periodic breathing, and depending on the device, it will address and assess flow or ventilation retroactively, looking at few minutes back, and try to imitate this in a fashion where pressure support will be provided in either an increasing crescendo feature, sort of to mirror Cheyne-Stokes breathing, to actually try to mimic what the patient is doing when it's not on central apnea. Again, ASV, if there is something important that I want to establish, is that never use this with the purpose of ventilating, because you're getting a variable pressure support any single time you're using pressure support, and it could be minimal if there are no true central apnea. So this is actually quote unquote a contraindication, if we want to call it about like that, in hypoventilatory syndromes, and more so in neuromuscular hypoventilation. I'm not planning at all to go into this formula. The only part I want you to look at is the blue square at the bottom, and what I try to emphasize there is that pressure and pressure support will depend essentially the difference the volume will depend in a difference in pressure, and that will also be affected by the time that pressure is exerted. So it's important to analyze the effect of pressure support, how much pressure is given, how much time is given, and in what fashion is that pressure delivered, meaning all the way from the get-go, or slowly, or increasing slowly from the beginning. And what we see there is that in spontaneous breaths, essentially, you're able to trigger a breath, generate a flow that will essentially, in bilevel PAP, generate a flow that can be given again slowly or fast, and that will define the rise, which is equivalent to the accelerating ramp, if you want to call it, and the square wave in invasive ventilators. And then that pressure will be delivered for whatever time you defined as an inspiratory time in the time mode and some specific modes within spontaneous ventilation, but I'll talk about that a little bit later. And then, all this pressure is delivered, you cycle, and you get into expiratory phase. The tidal volume is going to be dependent on this difference in pressures, assuming the lung mechanics and the lung compliance remain the same. The larger the difference between the IPAP and the APAP, the larger the area under the curve, and the larger the tidal volume that will be delivered. Time, as we will see, also matters on this. But one really, really important factor is if the breaths are spontaneous or not. When you're using a bilevel PAP ST, which stands for spontaneous and timed, the spontaneous breaths, obviously they need a trigger because you're triggering it, hence the spontaneous part, that will trigger the ventilator or the respiratory assist device to deliver a pressure that will generate a flow and translate into a volume. And at some point, you're going to get a decrease in flow as the lungs inflate and there is recoil forces acting to it. That decrease in flow is what is going to define the cycling, and not necessarily the inspiratory time. However, when you use time breaths, meaning you could be dead, the ventilator is just going to trigger the breath because you didn't, then what is going to set the cycling, the beginning of cycling, is going to be so much that decrease in inspiratory flow. Even though you may have a lot of recoil pressure, that ventilator or that rad is going to deliver that inspiratory time regardless of what happens. So your resistance to that is irrelevant. Hence, those those breaths are usually more steady because you have more control of the actual time that pressure is exerted as compared to spontaneous breaths. This is essentially what I just explained. There is no trigger. The cycle is not depending on effort on any other variable. This we have inherently mentioned. TI will define tidal volume. The longer you exert that pressure support, the larger the area under the curve, the larger the tidal volume. So for the same difference and same mechanics, longer TI, larger tidal volume. Most devices right now especially ventilators, but it's true for all respiratory assist devices, bi-level PAPs for ResMed, which is probably the most common use component. It's true also for what is Luna, and the name is just is not coming to me, React Health. It's also true for them. And the important thing here is that I want you to understand is that we're able to define two inspiratory times in these devices. And that's TI mean and TI max. The TI mean is the time that we define from the beginning of inspiration to whatever TI mean we define. And that time in ResMed devices and these other devices, it's mandatory. What I mean by this is it will act in practical terms as a PC breath or a time breath. So regardless of what happens, this is going to go through, and regardless of what the flow decrease is, this TI, the pressure you decided is going to be exerted. After that, there is a cycle window where effort and resistance and everything will take into place, and that's the time between TI mean and TI max. And once that you have reached a TI max, if you have not achieved the decrease in flow that is necessary to cycle, you will cycle regardless. Rise time, it's really important in certain diseases, and rise time is usually, depending on the device, defined by a number, or in many of the ventilators we use now is defined in milliseconds. And Philips used to have an equivalent measurement, which 1 is 100 and 2 is 200 milliseconds, etc. In patients with obstructive lung disease, you definitely want to aim shorter rise time. And that's the time between the initiation of inspiration and the time you achieve maximum flow during that inspiration, or you're exerting your maximum level of IPAP. It needs to be short because at the end, what you're trying to do in patients with obstructive disease is minimize the time you use to exert the pressure you chose to increase or maximize the expiratory time, and hence avoid auto-pipping and breath stacking. If you use the same short time in patients with OHS, you're probably going to be in the wrong place. And the reason for this is that these patients, as you see in the left-hand side, one of the issues is basilar atelectasis, which translates into those areas are essentially collapsed. If you exert the pressure very fast and in a short time, what you're going to achieve is a preferential, if you want to call it this way, inflation of areas of the lung that have larger compliance, meaning the apices, and it's going to translate into asymmetrical recruitment and probably no recruitment at all at the bases. And what happens is it can actually, in a way, temporarily worsen your VQ mismatch by reducing flow in the areas that you're preferentially ventilating. If you use a longer TIA rise time, on the other hand, in these patients, and this is very true for obesity hyperventilation, and I would take the very part is true for neuromuscular disease as well, especially with diaphragmatic paralysis. If you do this in a slower fashion, you will have time to, quote unquote, for this volume to distribute happily and create a more heterogeneous ventilation, and hence allow for recruitment at the bases. This is also a little bit of, and the reason I'm putting this here is because the next slide is going to show something very specific for ResMed devices, but it applies to all other devices. The reason is that spontaneous cycling matters, and it's usually predefined the device, and this is true. For example, I don't know if you guys have V6 is there. It's also predefined in many devices. For example, V60 on different modes and on VAPs, for example, will cycle at 75% of maximum flow. And that is important because you're able in both respiratory assist devices and ventilators to adjust both how easy for these devices is to provide the pressure based on the trigger effort and the negative pressure exerted, and how fast they will cycle when flow decreases. And that matters because, for example, in patients with COPD, you want them to have a harder time to actually trigger the device, because otherwise you can just start triggering one after the other and produce stacking of breaths. So you will use a less sensitive mode in these devices in patients with COPD. The cycle, on the other hand, you would like them to cycle early to decrease that inspiratory time. So you will use a high sensitivity in these patients. And again, remember, whenever you see a percentage in cycling, what you're seeing is what is left. What I mean by this is if you set most of these devices on a 20% or 50%, whatever you see there, 20% cycling, it means that the device will cycle once the maximum flow has increased by 80% and 20% is left. It's counterintuitive sometimes, but that's the way it is. But in patients with COPD, for example, in this, go low, make them difficult to trigger and cycle fast. And in patients with neuromuscular disease, make them easy to trigger because they have no strength, and make it longer for them to cycle because they will need that time. Because as the breath progresses in neuromuscular disease, they get weaker, even in one breath. So they need a longer support, hence a longer inspiratory time and a longer rise. Compliance matters. And this is important, and it's applicable to a concept of AVAPs. And the reason for this is that if you have a very high lung compliance, if you have a very low compliance, regardless of keeping the same pressure, your tidal volume will decrease. And the typical example where this happens dynamically is heart failure and pulmonary edema. Effort is also true, and this is very significant for neuromuscular disease. You decrease the effort with the same pressure, your tidal volume will decrease because you cycle early when doing so spontaneously. Auto level PAP, this is critical because, as we will see, you can have one device that is a respiratory assist device that happens to also have an auto BiPAP function. So if you may be able to get devices you can actually use to ventilate on the grounds of a stenting, meaning requiring an auto BiPAP for patients that is either use very high pressures on CPAP or they're intolerable to CPAP. And that's an interesting distinction because even though all these modes are different in terms of defining RAD or CPAP, when you put the devices together, this is one device, this one here, auto bilevel PAP, you switch and you have the same device, and auto ASV is a device on itself, AST is a device on itself, and then we go into the ventilators, where are a totally different animal. Ventilators, aside from providing the advantage and the necessity sometimes to have a battery backup, the typical example is CCHS, and have alarms. The typical example against CCHS and any other chronic vent-dependent respiratory failure. These devices and some of the RADs, very few, they have the ability of having an adjustable pressure support that it's able to change in time with the goal of either targeting a tidal volume or targeting immunoventilation, which is useful because, as you know, there are very different, the effort decreases dramatically, especially if there is diaphragmatic dysfunction or hyperventilation during REM sleep. So to achieve the same ventilation in these patients, you will need a higher pressure support. And these machines are able to adapt themselves and adapt that difference between IPAP and EPAP to do this. I want to remind you that VAPs, whatever variations of these AVAPs, IVAPs, whatever you want to call it, it's not a ventilation mode. This is a still bi-level. This is a still pressure support. It's just that it has a very specific algorithm that allows for adapting and targeting a volume. You can do many things on these devices. I'm not going to go into details. They have an integrated auto CPAP, if you want to call it that way. You can play with these TME and TI Max. You can tell the machine, and it varies very much depending on which device you're using and if it's AVAPs or IVAPs. In some you can tell the machine how fast you want the pressure to vary. In some is embedded into the system. The algorithms are very different. How patients react to this is also very different. I just wanted to highlight your ability to manage all this, and it gives you a great, I would say, a great room to make adjustments in these patients as their diseases progress. This is just to show a variation of pressure support between REM and non-REM. It's able to adjust for that. And I'm going to go into the cases now, and I know you're concerned for time, but we'll make it somehow. I can see your face. This is the smoking gun, and this is a patient with severe obesity, COPD, which is moderate, heart failure with reduced ejection fraction, and severe AHI, severe OSA 2 years ago. It's admitted with volume overload and a PbCO2 of 69 with an acute and chronic respiratory acidosis. It's placed on BiPAP 10/5. I don't know how common is that there, but it's very common here for 3 hours. And shockingly, is still having desaturations during the night at the 6s. We were consulted, and we have the ability to do unattended sleep studies. We have the ability to do as many gases as we want, as measure entitled CO2 in the patient, measure transcutaneous CO2. We can do bedside spirometry. We can do overnight oximetries, official ones, not the one that nursing does. We can place patient on CPAP and do studies afterwards. We can do many, many things. And it's a matter of choosing what is going to take this patient to a device in the easier fashion and more effective. So we know that this patient has obstructive sleep apnea. I mean, probably still has it, had an AHI of 48 2 years ago. Has extreme obesity, so it's likely that chronic hypercarbia is related to OHS, but we also know his BFTs are obstructive. So this could perfectly be at least obstruct OSA, COPD overlap, plus minus OHS. And we know based on the venous gas that the baseline CO2 is probably, the patient lives in the low 50s. There are many ways to get into a non-invasive ventilation device, and that especially in these patients with multiple overlap, you can use the obstructive sleep apnea road, the COPD road, the OHS road, and the other road. And I'm going to start with the other road because it might be tricky, but yes, do I use it? Yes. If a patient qualifies for CPAP and has AHI more than 5, you can get a RAT by claiming CPAP intolerance. Hopefully you're able to prove it. But many times the mechanism of getting these devices is so distorted that you use this as a way of getting a device for a patient you know you need to ventilate. The unattended sleep study showed a severe apnea, as not surprising, but it showed clusters of desaturation that are typical of REM hypoventilation. We know that these patients should be treated, and this patient has heart failure. So there is evidence enough to say that you have a decrease in mortality if you treat that overlap, and there is a decrease in mortality and increased survival if you treat the OSA COPD overlap. The COPD road, it's more complex. You need more than 52. You need an overnight oximetry of CO2 on a gas. Forget about CO2, forget about transcutaneous, forget about anything else. You need an overnight oximetry of 2 liters on 2 liters or more with the SATs less than 88% for more than 5 minutes. And you don't really need to prove there is any obstructive physiology. If you just say there is, that's enough. Your word has some value for this. Don't ask me why, but they decided that is the way. So this patient had a CO2 of 54. In arterial side, the rest is irrelevant for device qualification. the question is this 54, does it justify placing this patient on long-term non-invasive ventilation? I think the response to this is on a paper by Patrick Murphy in 2017, where he pretty much established if your CO2 is high enough, meaning more than 53, you will benefit in terms of admission-free survival by being placed on non-invasive ventilation. The caveat here is that he said that you have to wait 2 to 4 weeks for this to be true after the exacerbation and the acute episode. The hypoventilation road, I will just erase it from your mind in this patient. It's complicated. You need a spirometry. The patient already has a diagnosis of COPD, so you in reality don't need to go this pathway. And it has a little bit of a torture phase to it, and you need usually a sleep study to prove the saturations as compared to just an overnight oximetry. So what we did is this patient, we decided to go the obstructive sleep apnea road based on how close the CO2 was to 53, and actually by treating the severe sleep apnea, a repeat ABG in 4 weeks after showed, and I mean, not normalized, but pretty much lower CO2 that probably did not justify the use of a bilevel device. The smoker gun is the case number 2. Bad COPD, really much worse hypercarbia, and admitted with, again, acute and chronic. It was ventilated and extubated again to BiPAP 10/5. Not surprisingly, the CO2 didn't improve too much, and the patient was also noted to have baseline desaturations on bilevel PAP. We were consulted. Options obviously are the same. What is clear in this patient is that he just recently had a sleep study and he has COPD. So this is straightforward. BMI was low. This is a straightforward OSA COPD overlap with many other comorbidities, as we can see there. The VVG suggests that lives in the 70s in terms of arterial CO2, and the roads are pretty much the same. The other road, I think it would be unnecessary to do. We cannot say everybody's CPAP intolerant. That's not the case. There is no need to repeat a sleep study on this patient. Just had an HST recently, and I think the COPD is the most reasonable way here. The point I want you to learn in this case is that even though Patrick Murphy said that, and it's true, you need to wait a little bit. If your CO2 is really high, there is no way in this world it's going to go back to normal 3 to 4 weeks later. So it's funny, I was in a conference now, and this is his same approach in real life. But yeah, I mean, if somebody has a CO2 of 80, you don't have to wait 3 or 4 weeks. This patient needs to go home on non-invasive ventilation. Your choice of devices is going to be based on what you need to do with the device and what pressures you need to achieve. RATs, they have different limit pressures. BiPAP ST specifically, when it has IVAPS mode and A, it has a higher IPAP of 30. So if you really need higher pressures, you need to go to more complex devices. And that is true, obviously, for ventilators that can achieve IPAPs of 50 to 60. If you use a RAT or a home mechanical ventilator, depends on many factors. And what you're going to get through the route of COPD is a bilevel PAP-S. Getting an ST is extremely complex in this pathway. And you can use this device with the 2 modes to figure out what EPAP you need without a titration, just by using the EPAP 95 on the auto mode, or you can bring the patient for a BiPAP titration. Patients that have comorbid, rapidly progressive diseases, ALS, or highly variable lung compliance, a typical patient is a patient with heart failure or hemodialysis, where lung with volume shifts can decrease compliance easily. And patients that require really high pressures, as I said before, probably will need a home mechanical ventilation. We went the COPD route to get a RAT. We did an overnight oximetry on bilevel PAP 20/5 on 2 liters of oxygen. There were REM cluster desaturations, with sawtooth pattern, which suggested that probably the EPAP of 5 was not enough. we ended increasing the pressure, the patient to 22/8, and on the grounds of hypercarbia and desaturations on that overnight oximetry, the patient was discharged on a bilevel PAP, 23/8, which happened to be effective, but you can also do the bilevel PAP abroad, as I said before. The triple shot is a patient that has it all, BMI of 62, ABG also with extreme hypercarbia, and a chest X-ray that suggests COPD, and I'm sorry, a CT that suggests COPD, and a chest X-ray that shows a previous thoracic surgery. This patient was admitted with acute and chronic hypercarbia respiratory failure, again extubated to very low pressures. The ABG, after being on non-invasive ventilation on this very low level of pressure support and very low TI, which is important to remember, showed significant hypercarbia and desaturations. We were consulted. Again, patient possibly has ASA, has severe obesity. We know has COPD. We know this is probably a triple overlap. And on top of that, there is probably some neuromuscular part of this because the patient had prior surgery, and that could induce some restriction, thoracic cage restriction, and perhaps you need to be very aware of the diaphragms. We did doing a sleep study in this patient is probably a really bad idea, has significant hypercarbia, and we know that even with some pressure support fails. So CPAP intolerance is not the route to go. The COPD route could be used. There is more than 52. And again, just by saying, regardless of the spirometry and regardless if this patient in reality has obesity hyperventilation, based on emphysema on a CT, you could say that this patient has COPD. And if you add an overnight oximetry on 2 liters or more for less than 8 minutes, you could qualify even if the disorder is truly mixed. The hypoventilation road, again, is complex. And you need, in the COVID times, we were able to use overnight oximetry, but now more and more the sleep study is required to prove these desaturations for more than 5 minutes. The other road is restrictive thoracic disorders. And this is the X-ray in this patient where the left hemidiaphragm was actually elevated. And it makes things much simpler because if you're able to properly document, and I'm gonna fly, let me see if I can fly through this now. So if you can properly document that there is a thoracic cage disorder, you only need a hypercarbia of more than 45 or an FEC of less than 50 or an EF of less than 40 to be able to qualify these patients for actually a BiPAP ST device. It's your choice between BiPAP S and BiPAP ST. What we did was a COPD road. We ended putting the patient on bilevel on a BiPAP S, and he was taken to a titration afterwards to titrate oxygen. This is a patient with a severe scoliosis with a very weird genetic disease that translates in progressive weakness and has clear chronic hypercarbia on an ABG. When you look at this, and this is a point that I want to bring up, this is a chest X-ray versus a CT scout of this patient. What is interesting is that, and I'm getting some very specific data on this, is that I came to the realization that we can measure actually, I mean, both the scout and the upright chest X-ray, they're done on inspiration. And if you measure the distance, what you have in reality in the scout is a quote-unquote chest X-ray in the supine position. So sometimes looking at this can be very suggestive of diaphragmatic dysfunction. I don't know if it's true or not, and that's what I'm trying to figure out with numbers. But this particular patient, there was significant diaphragmatic dysfunction as proved by a change of more than 20% in FVC on a supine versus upright spirometry, and also a decrease in MIP. We used bilevel PAP ST on those grounds, and we were able to obtain an improvement in CO2. The other thing we did is we're able through slow DMEs to obtain overnight TCOM in these patients. And as you can see there on bilevel PAP S, on 20/5, we were able to see that there were still clusters of desaturation, which suggests that this continuous pressure without an assured TI and probably early cycling secondary to decreased effort translated in transient hypoventilation during the night. And that's why we decided to use ST in this patient. This is part of the REM curse, where, you know, I think REM is a poor design of nature, but it's the common factor of all hypoventilatory syndromes. And you see in early neuromuscular disease, you see it before overt daytime hypercarbia occurs, and the same is true in many cases of COPD and obesity hypoventilation. We got the neuromuscular road. As I said, you can get whatever you want as long as you check one of these three parameters. And in this particular patient, we decided to do a home invasive ventilation. The reason there was progression into her disease, and that's something you need to factor when you order a RAD versus a home mechanical ventilator. This is what we did in the hospital in terms of AVAP settings. At home, we transitioned to a trilogy ventilator at that time. These were the settings we chose. There is a significant component of neuromuscular disease, so we chose a longer TI. As you see, the rise was longer for the reasons I explained before, and we cycled it very late because these patients with neuromuscular disease need to get as longer support as they can. 2 months later, you can see that there is the minute ventilation is on target. There is a steady delivery of pressures, and the CO2 has pretty much normalized, which is proven by a home overnight CO2 measurement. The next question is, how do we do this in the hospital? And you need to get a device and send the patient home, and you need to qualify the patient for the RAD or home mechanical ventilation. You need a timely process that does not increase length of stay. And for that, you need the device to be authorized, you need to be set up in the hospital, you need to be able to educate the patient and titrate and optimize therapy. So you need a team and you need collaboration. And what we did is we started with an inpatient sleep service that initially had like 1 console or 2 consoles per week. And then, I don't know, I decided to somehow transform this into a Frankenstein. And things you need to do is you definitely need to involve a DME. You need to have a lab because many of these patients need a titration study, either for oxygen or for ventilation. And you need to be able to follow up these patients because follow-up is essential in being effective on this therapy. This is a Frankenstein theory I was saying, and the reason I said that is because we started on FA fiscal year 18 with 450 consoles. We have a projected of 6,000, not consoles, but unique encounters between consoles and follow-up. So yeah, it's not good. And this is only one hospital, so we're hiring. The daily census is anywhere between 12 and 25. I correct that. We had 27 the other day. We get between 3 and 10 new consoles per day. More than half of them are non-invasive ventilation, actually. This service is pretty much driven by nurse practitioners that are very independent in their actions, and they're very well trained. We have 4 nurse practitioners, but they rotate in different ways, and essentially we have 2 full FTEs. Our model uses pulmonary critical care physicians to staff this. When I say physicians, it's essentially 2. Again, we're hiring. It's not that I'm using this to recruit people, but yeah. The inpatient consult service is able to do 6 or more studies per night. Again, remember that we cannot bill for any of this. So the patient is hospitalized, we cannot bill for an outpatient test. Hence, the only reimbursement we get from this is the professional fees for reading the sleep study. We can do overnight oximetries, same concept is true. So ideally, you should get a programmatic support from your institution to do this. We take the loss, and at the end, when you calculate things, in our case at least, the math is not that horrible. You need to partnership with respiratory You need to be able to measure T-COM. You need to do bedside spirometry on NIF, and that partnership is essential because you need this test to qualify patients. And you need to have an outpatient follow-up coordinated before discharge. So our nurse practitioners sometimes schedule. We have administrative assistants that are, in Epic that are able to coordinate all this. But this is really, really important. Otherwise, this is highly ineffective. This doesn't make money, just to let you know, but at least in our case, this is the analysis of somebody we just hired, a nurse practitioner. We have net operating a positive net operating margin. That being said, in this calculation, we include the studies that are ordered, the in-lab studies that are ordered in the patient service. So we assume that as downstream revenue. You need, and this is what I mentioned before, you need in-house training, you need RT training. It's very interesting how poor knowledge of AVAPs specifically is in the respiratory therapist, at least in our cohort. But creating an education program about this is extremely important, and it's not only reserved to, and I would be unfair to say, I mean, when you look at pulmonary critical care fellows, train in many places, the understanding of these modes of ventilate, of these modes and these algorithms is extremely poor, and AVAPs is like a taboo, which in reality is BiPAP. But you need to have a very good established DME partnership. We have liaisons in the hospital. You need to have an EMR medical record, electronic medical record driven prescription system where you can actually flow things. You can write a prescription that is authorized immediately by the DME. So you need to create this flow, otherwise you're increasing lengths of stay. We have a liaison that is able to set up the device. So if we do a sleep study one night, we read it in the morning, the patient can go home the same afternoon with a CPAP device, just to give you an example. And one of the other things we do is that sometimes you have 48 hours, you can set it up 48 hours before. And if we activate the modem directly, we can actually get data directly from the patient that is still in the hospital. And that's useful for management down the road. And I'm gonna go into details for this. It's important that you have transitional care programs. This is a nursing study, and that it's established that for this to be effective, you need training and education and a program. If this has clinical implications or not, I can tell you that for obstructive sleep apnea, yes, it does. This is a study by Sunil Sharma, who was at Jefferson in Philadelphia. And he proved that, if you study people and you place them early on CPAP, they come back less when they have heart failure. The readmissions rate for cardiac patients is not necessarily true. And this is a study from Rich Schwab at Penn many years ago. And what it establishes is that what matters in terms of reducing readmission is that you use the device, not surprisingly. So time of use matters. And what your ejection fraction, it matters as well, with a trend of full users that have a decreased ejection fraction, that patients with poor, with significantly decreased left ventricular function, regardless of the use, they're not going to do well. This study analyzed a cohort of largely old patients with very high CO2. And unfortunately, it found that placing these patients in non-invasive ventilation was not good, actually, for survival. However, these numbers were largely driven by patients who had heart failure and who had unsupervised NIV, who did not receive any education before discharge. Those that had supervised NIV actually had an advantage. So that highlights the point that you need to have a system where these patients are properly educated and placed on this. There was no true readmission difference. And this study shows that this is a study from centers in France. And it shows in this population of chronic respiratory failure, which is very much shifted towards neuromuscular disease and use a very high intensity pressure support, that in reality, there is a decrease there is a percentage, a decrease in mean survival. But if you take all these populations and you take COPD, it's driven down. So obesity hyperventilation is perhaps the disease that most benefits from this early initiation. And conclusions, it's feasible. We are not sure if we're doing the right thing. We need to do this and be clear about what population would benefit the most from this. We know that COPD with high CO2 does. Outpatient screening and before the event is ideal. The index event is ideal. So if we recognize this before they get admitted, much better. Compliance, supervision, and education, it's essential. You need to get many teams together. You need to understand that education is needed. There is very poor understanding on non-invasive ventilation in both physicians and respiratory therapists, and we need to have a really deep understanding of the disease and the Medicare insurance intricacies to be able to authorize these devices. And it went too long. My apologies. That's it. Questions?
Thank you so much, Dr. Mora, for this excellent and very practical presentation and, sharing your NIV titration at Penn. I will open this for any questions. I don't have any questions, but I had a question if no one has. So, with the new CMS guidelines for NIV, for COPD patients with removal of the overnight oximetry now, more patients could definitely qualify for NIV for COPD, especially. So in these hypercapnic COPD patients, how do you manage starting NIV? Because with the Murphy trial and many other trials that have shown that the hypercapnia does resolve for some of these patients, do you wait to start NIV or do you start them right away? How do you do that?
So again, I mean, it's do I wait? It all depends on their CO2 level when they're admitted, and again, this was so. Alejandra Lastra was also in this meeting. We were last month, and actually, it was Murphy who did the talk, and in the question sessions, that's what we brought up, like how do you do this? Because I mean, it's absurd to think that patients with significant hypercarbia and what we call significant hypercarbia, what is a number, there is no number. I mean, if somebody is definitely 90, it's not going to get better. But what happens with the 60s probably is reasonable to wait a little bit longer. The 50s definitely wait longer because you're going to need that. You have no idea what the CO2 is going to be for weeks for many factors. But I think the conclusion there was that if anything above 65, you want to have a some random number that we may choose, as many round numbers are chosen, that would be the number I would choose. I mean, if you're more than 65, there is no way in this world 4 weeks later you're going to have less than 53. So just start NIV early.
It's 3 p.m. So if people wants to leave or have to leave, that's fine. Anyone who has any questions, please feel free to unmute yourselves. Or if you can have your questions in the chat room.
Happy, that's my email. Happy to do anything, and just let me know if you have any questions. I will be happy to answer them via email. All right.